The rhythms of restlessness. Hands resting gently on my thighs, a subtle tremor stirs beneath my skin. Arms lifted skyward, the cure awakes. Each tremble grows a restless din, what's unseen rhythm grips my limbs and spills the water from my cup. What ghostly force will still these waves and bid my wavering hands be up? Tell me, tremor, what is your name? How shall I soothe your tireless flame? A nice poem which has been generated with ChatGPT shows the person's tremors, his difficulties, what he was asking me when he had presented to me about what are these, why I'm not able to do these activities. So this shows us the requirement of us to have an approach to tremors. A tremor which was seen in this person while he was keeping his hands on the thighs, while he stretches his hands, which increases with time when he keeps outstretched hands, and then he's not able to do his day to day. How to name them, how to treat them. What is that? What is required? We require something is called as approach to tremors, and that is what I'm going to cover. I'm going to talk about why is there is importance for an approach. I'm going to limit my talk primarily to the consensus statements of the 1998 and 2018 of the Movement Disorder Society. And I'll talk about some of the controversies and limitations. With that, I'll be concluding my talk. So why it is important? Each tremor, based upon geographical, the authorities' preferences, everyone views in a different way and describes in a slightly different way. And sometimes a uniformity is required so that every person can understand what does terminologies means. Hence, to address this, the specialists or the authorities on movement disorders and tremors had met in Kiel in Germany, and they came up with terminologies to foster a consensus. They decided one thing: the tremors can occur due to various physiological basis or etiological basis, but for day-to-day practice, the clinical classification remains the gold standard, and that is what has to be done. And in 1998, they came out with the consensus statement of the Movement Disorder Society for Tremor. Herein, in this consensus statement, they define the phenomenology of tremors, they define the terms related to tremors or tremulescence movements, and how to assess a patient with tremor. And also, they try to give some clarity on syndromic diagnosis, such as clinical definition of enhanced physiological tremors, subclassification of essential tremors and Parkinsonian tremors, classifying dystonic tremors as a separate entity, and pulling palatal tremor or palatal myoclonus as into a tremor syndrome, and defining Holmes tremors as a substitute for misnomer rubral tremor. The group decided that tremor is something is an rhythmical, involuntary, oscillatory movement of a body part. That is how you define a tremor. But this tremor can occur into various situations. So based upon how it occurs, you give different names to that. Tremors that occur in a body part that is not voluntarily activated and is completely supported against the gravity, that is ideally resting on a couch, is called as rest tremors. These tremor amplitude can change with various activities such as mental stress. And then you can have people who do not have rest tremors, but when they produce voluntary contraction of the muscles, that is tremor that is produced by voluntary contraction of muscles, including postural, isometric, and kinetic movements, are called as action tremors. These can be just postural when the tremors are noticed when you have outstretched hands, or this can be kinetic when these tremors are noticed during any voluntary movement, such as simple whole length of the movement, or intention when you're trying to touch something, or task specific when you're doing able to do only certain type of task, like playing a sport or writing, something like that. Then you have isometric tremors, where tremors are appreciated when muscle is contracted against a rigid stationary object. For example, holding a shopping bag, keeping the hand on the table, gripping the fingers of someone, you notice it. So those are the broad classification of tremors what we notice. So how to assess the tremors? Always first inspect the tremors, then see which topography it is involved, the body parts which can be cleanly identified and meaningfully described, and what happens to these tremors or how these tremors are noticed with different activation procedures such as mental activities, rest posture, postural intention, task, and co-activations. And if you have a possibility to see what is the frequency of these tremors, whether they are low frequency between less than 4, medium between 4 to 7, and high frequency is more than 7 hertz. And are there any, in addition to tremors, are there any other neurological examination findings or other systemic signs which can give you a clues to diagnosis, and any other specific medical or family history which could help us in further narrowing down. This is how you inspect for a clinical assessment of tremors step by step. So based upon this, you classify the tremors as phenomenally based, as I explained, rest or action tremors. Action tremors can be dependent as postural, that is position dependent, position specific, or action kinetic, which can be simple kinetic, target directed, task specific, or isometric action tremors. As I already told, if the facilities are there, we can also have frequency based, that is low frequency, medium frequency, and high frequency tremors. And with these things, we'll be able to classify them a mixture into go into a syndromic diagnosis. And these syndromic diagnosis will take the phenomenology, frequency, and underlying cause as giving a name to them. So the consensus statement of 1998 came up with syndromic tremor classifications as physiological tremors, enhanced physiological tremors, essential, dystonic tremors, Parkinsonian, cerebellar, Holmes, palatal, drug-induced or toxin-induced tremors associated with neuropathy, psychogenic at that point of time, and unclassified tremors. Those tremor classifications were fairly good enough to be utilized, but over the time, some limitations were seen. What these limitations were, there were regards to essential tremor classifications. So, what to tell when essential tremor is associated with other signs or symptoms? Do we still classify it as essential tremors or it is something else? Because many of the essential tremor have a lot of soft signs. It can be in the form of impaired tandem. There may be some dystonic movements, associated head and neck, tremor start, asymmetry of the symptoms, or there may be more than one etiology causing the tremors or multiple tremors seen in single etiology. There was also issues in related to tremors associated with dystonia or in presence of other additional neurological abnormalities. It was also noticed there was some lack of consistency in naming. For example, many times it was presumed to have anatomical origin, but however, the naming included at one point as cerebellar tremors and another point as intention tremors. Both of them imply the same. And sometimes the etiologies were presumed etiologies were used, such as naming them based upon Parkinsonian tremors and neuropathic tremors. So it may not have given the ease of classifying for newer syndromic diagnosis. And tremors were based upon pure clinical phenomenology. The clinical phenomenology did not allow them to isolate them into a group of disorders, like as primary writing tremors, orthostatic tremors, isolated voice tremors. There are isolated tremors. So why should they have separate name? They can be subclassified under isolated tremors. So in 2013, further, the new set of team they met in Lisbon in Portugal and they wanted to have a classification scheme that promotes detailed phenotyping and to have more broader and ease way of research for various etiologies. And they came up with the newer consensus statement of classification of tremors from the task force of tremors of the International Parkinson's and Movement Disorder Society. And what did they do? They went in axis based. Axis one was clinical feature basis and axis two, which will give the etiology. So that the symptoms can be more broadly approached and you have a scope for to have naming and better research abilities associated with that. So what they did in axis one clinical feature, they wanted to look into four features. One is historical features, where you look into age at onset, temporal onset and evolution, how the symptoms evolved, was there associated with past medical history, family history associated, and sensitivity to alcohol and various drugs. For example, age at onset was divided as infancy between 0 to 3, childhood onset between 3 to 12, adolescence between 12 to 20, early adulthood from 21 to 45, middle adulthood from 45 to 60, and late adulthood after 60. So each one of them gives you to classify how the tremors at what age, was there acute or subacute, response to therapies, response to medications, they historical features will give out. Then, based upon next is to look into tremor characteristics, to look into which body part is involved, what happens to tremors in different activation conditions, and what is the frequency of tremors. Then, whether these tremors are associated with any systemic illness, neurological signs, or just some soft signs are present. And then, what value addition does other additional lab tests. It may be electrophysiological tests, structural imaging, receptor-based imaging, or serum and tissue-based bio. So based upon this, here you get an isolated way of looking into tremor individually and then combining them to give an etiological causes, which is the axis 2. These etiological causes can look into acquired disorders or genetically defined causes, or it could be just be idiopathic, which can be familial idiopathic or sporadic idiopathic causes. In both the papers, there is an extensive list has been given, the figures of which has been put up here for your brief review. So this is how you reach out to the etiological causes, and this gives you a better understanding. These etiological causes in general can be neurodegenerative disorders, chromosomal related disorders, various genetic diseases, infectious and inflammatory disorders, endocrine and metabolic, neuropathies, drugs, toxins, and so many others which remains unanswered. Based upon this axis and axis 2, similar to the first initial consensus statement, tremor syndromes have also been described here, where it helps to better labeling. So based upon predominant type of tremors, whether the person has action or rest tremors, the tremors can be essential tremors and essential tremor plus syndromes have, tremor plus syndromes have come in. Isolated segmental tremors, where they involve one or two contiguous body parts. Isolated rest tremors, if it is not involved with any other neurological signs, either clinically or electrophysiologically. And then enhanced physiological tremors are there. Then you have focal tremors, which involve only one specific type of movement, such as voice, head, jaw, face, and other body parts, or essential palatal tremors can be noticed. You have task and position specific tremors, such as writing, sports, or musicians, or tremors associated with additional signs, such as dystonia symptoms, Parkinsonian symptoms, associated cerebellar features, or symptomatic palatal tremors, what can be noticed. Then if tremors are primarily noticed on standing, that becomes as orthostatic tremors, and primary orthostatic tremors are usually defined between more than 12 to 16, between 12 to 16 hertz. However, sometimes you notice primary standing tremors or orthostatic tremors with lower frequencies, which are called as pseudo-orthostatic tremors. And then you have finally others, which includes functional or tremors, which cannot be defined based upon the current syndromes what we have utilized. Now let's go to few of the examples. Here you see an young man who has early adulthood onset, subacute onset, tremulousness of his outstretched hands. It's primarily postural upper limbs tremors, which are noticed when he's more anxious, associated with anxiety and palpitations, and his metabolic screening done shows features of hyperthyroidism. So axis 1 I have written on the left hand side, and axis 2 we know the cause is endocrine or metabolic induced tremors down there. The next case is an adolescent onset tremulousness, which primarily seen segmental, which involves the limbs, primarily postural tremors. In addition, you can see posturing, nice posturing of the fingers, so dystonic posturing is there. Right hand is more involved than the left hand. When you see investigations were done, MRI was showing bilateral basal ganglionic and thalamic signal changes, and blood parameters had shown increased low ceruloplasmin levels and increased 24-hour urinary copper. And this is a case of a tremors noticed in Wilson's disease. So it's a metabolic cause of a will dystonic tremors occurring in a adolescent onset patient. Then people with various neuropathies can have tremors. This was a person who had a middle adulthood onset upper limb postural tremors, which were noticed following during his recovery phase of recovery from Guillain-Barré syndrome. So there was no other associated primary tremors. So this was a primarily neuropathic tremors what could be noticed in this patient. Primarily postural tremors what can be noticed. This person presents with early adulthood onset task specific because he does not have tremors in any other position, but only when he wants to write, he starts having difficulty in writing. You can see there is a rhythmic movement with pronatory supinatory movements of the forearm and the wrist region with which he is having difficulty in writing. So it's a primary isolated primary writing tremors what can be noticed now. Then coming to the next case is a classical Parkinsonian tremor. You can see there is a middle adulthood person while sitting, he is having a classical right hand, left hand pill rolling type of a tremor what you can notice down. And this is isolated hand tremors. And when he stretch out, in addition to those tremors, you can notice that there is slowness in his movement, facial hypomimia is there, and tremors which are not noticed initially in outstretched hand, they start rebounding and occurring back. So that is Parkinsonian tremors, what you could notice down there. Next, coming to a lady of a middle adulthood who tells that I can't stand. When I stand, I feel something uncomfortable. When you're trying to see there, you are not appreciating anything, but at best you can see her sari is slightly shaking. And when we did an electrophysiology for that, there was about 15 to 16 hertz tremors, what we could notice. And she had primarily in orthostatic tremors of unknown origin because etiology was not yet defined. Similarly, another lady with late adulthood who had lower limb tremor. Similarly, you can see that the previous lady you are not able to appreciate. This lady you can able to appreciate more prominently tremors. The tremor frequency was less than so-called defined for the orthostatic tremors. So this is a case of a pseudo-orthostatic tremor occurring secondary to myelopathic changes in the myelopathic changes in the spinal cord. Then we come to the next set of tremors. Those are palatal tremors. What you can say, these are palatal tremors are isolated tremors which can occur due to involve rhythmic palatal movements with 0.5 to 5 hertz. There may be essential palatal tremors, secondary palatal tremors, and functional palatal tremors, and the etiologies vary based upon patient to patient. Then this is a case of a middle adulthood onset with, you can see, hemi-body tremors. Basically, he's having right side tremors, no tremors on the left side, which is action more than postural, more than rest. And these tremors had occurred following bout of recurrent vomiting. MRI had shown signal changes in maxillary bodies, periaqueductal gray area, thalamic and tectal plane. So he was diagnosed to have Wernicke-Korsakoff syndrome and the tremors following that, which could be noticed, which is an intentional tremors, what is noticed down here. Then the other common issue, what we notice in day-to-day practice is people presenting with tremors, which are distractible and modifiable. These are called as functional tremors, what we notice. Further, we can have isolated voice tremors. I don't know whether you're able to hear the voice here. This lady is having primarily when she's talking, there's a tremulous sense of the voice can be noticed. Then this is a drug isolated trunk tremors, which is probably drug-induced or tardive tremors, what you can notice in this lady. So axis 1 and axis 2 based, I'm trying to give different examples to see how these tremors look into it. Now we can see a tremors with the early adult onset following a liver transplant. Probably it has acute drug-induced tremors, what was noticed in this patient. And finally, we can have tremors wherein we can't define that. This is a lady who had a middle adulthood onset tremors, primarily upper limb tremors, which are primarily action more than postural with a strong family history. However, the tremor duration has been about 2 years. Currently, for classification of essential tremors, tremor duration is required to be at least for 3 years and more. Probably it could be an essential tremor, but at this point of time, these would be classified under as indeterminate tremors. So with these contours, the first consensus had come up with lot of answers and lot of guidelines, and it helped us a lot way. But down the time, there were some limitations were noticed, and then the second consensus came. Even though it tried to improvise upon that, it had its own sets of problems and controversies, which can be seen in different publications which has come subsequently following that. These issues are in relation to definition of tremor. The primary question is tremor is a symptom or a sign? Means, do you want to, if someone tells I feel tremors, do you want to consider it as a tremors or no? Or is it just a sign which has been clinically elicited? How to define? It is not clear from the definition. Whether tremor is always involuntarily, because we have defined the tremor as an involuntary rhythmic oscillatory movement. If someone is moving a rhythmic movement, or they are doing, or a maligning person who is doing a tremor, or there is different functional tremors are there, do you want to call it as tremor or do you want to call it as a different name? And how to define involuntary movement that is oscillatory but not strictly rhythmic, because we have used three terms. One is oscillatory, one is rhythmic, and one is occurring in the body part. So when we are looking into it, if there is a certain frequency is there but not rhythmic, it comes and goes with various frequencies or various rhythms, what do you want, or arrhythmic, what we call it as, do you want to call them as tremors or not? These questions are not remains unanswered with the current consensus. And further, we are trying to define isolated tremors, but further these isolated tremors we have redefined into primary writing tremors, orthostatic. They also primarily fit into isolated tremors. Why we are trying to define them separately? They should have fit into a single broader diagnostic approach. And definition of essential tremor. This is where a lot of controversies remain, because the duration of 3 years which has been utilized is being considered as arbitrary duration component. And there is no clear emphasis on kinetic component, which is primarily required for define essential tremor, where many authorities feel in that direction, and that has to be addressed in the subsequent probability definitions. Even though these issues are there, but at different multiple levels, the tremor severity, many times the tremor is a severity. Sometimes patients having tremor, they don't have any problem. Some people with mild tremor, they have a lot of issues. The severity component has never been addressed in these tremors. So these needs to be addressed. There are further issues with classification by defining essential tremor plus. Means essential tremor plus means you have essential tremor with plus means essential tremor person developing dystonic movements or dystonia, or dystonic person is having the essential tremors. How do you want to classify? Or how do you classify presence of other essential tremor developing into Parkinsonian disease, or Parkinsonian patient developing into essential tremor? Or what is it to define? A lot of confusions are there in relation to classification or defining. And as already told, issues of defining primary orthostatic tremor and orthostatic tremor plus, and absence of hierarchy in terms used. If you use certain terms, under which terms those fall in. So there is some loss of clarity is there, and many of the authorities have tried to see that we need to address these things. But as of now, this remains a better way to approach or classify patients with tremors. Now coming to evaluation of tremors. As already told, the axis 1 predominantly defines how to examine them, including tissue biomarkers, electrophysiological tests, structural imaging, and receptor-based imaging. There are various assessments options which are available, which includes physiological-based assessments using accelerometer, EMG, computer tracking, subjective scales, objective scales, and quality of life related. These can be utilized based upon the primary goal of the treatment, what is being planned. And as important, even though my primary goal has been on approach to tremors, a short coverage on therapeutics. There are different therapeutics which are available, including physical maneuvers, benzodiazepines, anti-epileptics, dopaminergic medications, botulinum toxins, surgical options, which include in addition to non-medical management. The same person's video which I had shown previously, I am going to repeat it here and show that how his tremors have gone. The ones bound by QR hands Uncertain, dear, now guided gently by science light, the cup of water rests its brim held near. Each written stroke now steadily through the night. The tremor whisper fades to calm and peace, as daily tasks emerge without a fight. Life pulses on with newfound sweet release, a steady rhythm born on hope's inside. The person was not able to hold a cup of glass to drink, now is able to comfortably drink the thought process what it comes. I'll definitely thank ChatGPT for getting me this poem, the patient he was putting in his own language to put it down into a better format down here. So yes, tremors can be treated by medications. Tremors can be treated by surgeries, various different types of surgeries. Listening surgeries are there, invasive listening surgeries, non-invasive listening surgeries, and DBS remains the choice for patients with resistant tremors. And you can see this is an example of classical tremors with a person who is having rest tremors, what you can see. And as soon as I switch on his DBS, the tremors completely vanish. So within couple of seconds, the tremors almost go away. You can see his bradykinesia also improves, hence showing an examples of medication-based management and tremors improving with surgical-based management. Finally, to conclude, tremors classification helps in better systematic approach. It allows scope for clinical evaluation, cross comparison, and management outline. Even though still very enigmatic status where idealistic approach and consensus is waiting, the current approach helps in better uniformity across the globe for management. And what I can tell is axis 1, go for clinical features. Axis 2, the etiological based approaches. With this, we'll be able to manage much better. Thank you. Thanks a lot. Any questions? I'll be able to take it at the end of the session. Thank you. Thanks once again.